UMLA ke mau keruat bar nekton el tongkhar ulawan ra da kamat detai halor ke jing Donkam bandon no da ki jaka sumar bakerpang lani ke comfort care haki hospital nak bentai ki Nongpang ki bala shitom jur bad ki badon ki Jingpang ki bala khamne Slem ki badai na ki long yeng ki badu haba benrap lang UMLA ke Sning Dr. Celestine Ling Dopan ulaong baka Sorkar kade bandon da ki kenja kenhun kaban pej benia namar dala de ulayo I badon bun ki kep baki long yeng ki kidram habadon ki dekot ke yeng ki bayo yakum ki te ki Jingpang haba juba halor kane ka menteri ketenat ke koit ke khia kong amprin deng do kaloong bana kalian ke Sorkar kilapen klanya kilat jing sumar bat ki jaka sumar bat pentip ru baka Sorkar ka bu thong ban kentiu kerdan shu ki jaka sumar.
Thank you, Deputy Speaker, sir. I beg, sir, to move that this House do now discuss the need to provide comfort care treatment facilities to patients in the government hospitals.
Motion move. You may initiate the discussion, please.
Sir, I'm very happy that this motion came in this session today, even though I tried to brought this same motion in the last session, but it could not come. So you may surprise why this subject is so important to me and why I tried to bring, even though it doesn't come in the last session, but I decided to try this session again. And I must thank the Assembly Secretariat for allowing this motion to be taken up today. Sir, I may not be a right person to speak on this subject, but I'm happy that in front of me we have got many doctors, we have got medical doctors, specialist doctors with us in this ACOS house, and it will be very, very good for the benefit of this ACOS house and the people in the state at large if medical doctors can participate, if they wish to participate, to bring more light on this motion. Sir, people may think, and we members also may think, what is this comfort care treatment? And most of us, we don't want even to discuss, and we don't want to avail this service or this comfort, because it speaks about the end of our life to get such kind of comfort. So we don't want, but the fact is that everybody will have to pass through this at the end of our life. Even though we don't want, but we will have to experience this at the end of our life. Sir, if I look to some dictionary who explain about this comfort care, different dictionary may say different words, but one dictionary which I would like to read out here, it says that comfort care treatment is the comfort care treatment include physical care, emotional care, social care, and spiritual support for patients and their families. The goal of comfort care is to control pain and other symptoms so the patients can be as comfortable as possible. Comfort care may include palliative care, supportive care, and hospice care. This is the dictionary, sir. Sir, talking about the comfort care treatment, we understand that it requires to those patients who are facing chronic diseases and to the patients where between life and death. There are times that doctors feel the need to disclose to the relatives that this patient, it is not possible to cure anymore, and we find it very difficult to have hope to cure these patients. There are times that doctors, they felt the need to disclose the stage of the patients to their relatives. And we know when such information comes to the loved ones, to the relatives, to the attendants, we understand the emotion of the attendants, of the loved ones, of the patients at that point of time, sir. And most of the time, the patient, the relatives or the attendants, when such information came to their knowledge, what they do, most of the relatives, especially the poor people, the poor family, they opt to take the patient back home. When such information has been brought to them, that this patient, it is not curable anymore. So the poor families, of course I'm not talking here about the rich families, where we can afford better treatment, to go to a private hospital, to spend in a private room, and to get all the facilities that is available in the hospital. But I want to discuss here about the poor family who cannot afford such facilities. And I am really concerned about the poor family, poor patients, and maximum of the patients who are there in government hospitals, sir. It is poor families. It is the patient who come from poor families. So we understand, sir, when such information brought to them, what they do, most of the time, they decide to take the patient back home. And we can understand one thing, that in a poor family, what can these poor people can give, what kind of treatment in their homes? It is not possible, sir. It is not possible to give the treatment that is required to the patient at their home. They cannot do anything. The only comfort is that to the attendants, they will feel free when they reach home. They are free from that hospital atmosphere for which they don't like. So when they go home, they are more relaxed and more happy. But I'm talking here about the patient. The patient, when he has taken back home, he will face all pain and agony. And who can take care of such kind of patients at this poor home, at their poor family, sir? So why I'm so concerned for this subject, even though I said at the opening remarks that I may not be the best person to speak on this subject, but because I have the opportunity in the family to always talk about health matters, about health subject, because I'm fortunate to have my daughter who is a doctor, and I have my wife who is a nurse, and myself also, I'm privileged to be a student of MBA in hospital and healthcare management, for which I'm still studying, sir. So that's why I have the patience to spend time to think, and I have written also in my assignment on this matter. Sir, it makes me more concerned when I know some family are facing such kind of problems in the rural areas. I will not name the village. I will not name also that particular patients. But I know there was an instance that one patient committed suicide himself because of the non-availability of such kind treatment at home. One patient, after taking 4 or 5 hospitals, from one hospital to another, and their families, they are poor family, they find so difficult to spend. Whenever they take the patient to hospital, they keep a long list of prescription of medicines, and they have to buy those medicines. But this poor family can no longer afford to provide those medicines that are required for that particular patient. And at the end of the day, they also understand from one hospital after another that the hope to cure this patient, it's not there anymore. So ultimately, what they do, They understand this and they take that patient back home, waiting for the time to die. But that patient, he didn't die for so many days, so many months. The family member, sorry to use this word, they thought that they will take home, and they know also that he is going to die after a few days. But he didn't die. So ultimately, this patient, he has to face the pain and agony every day. And he don't dare also to tell the children to go to hospital again, because he know the condition of that family. It is a very low-income group family. And he knows also the fact that he had spent during the treatment all the resources that he have. It has been spent already. So he has to face this pain and agony at home, sir. He has to face that pain and agony at home every day. And what happened? On one fine day, when he see that there is an opportunity, when all his children is not at home, he take that sad decision to hang himself, and he died. This incident
Yeah.
sorry, sir, I'm emotional on this. I'm emotional on this matter. This incident has touched my heart, and I thought the government can do something to prevent such incidents. The government can do something to prevent such incidents, because we have so many poor people, so many poor patients in the state of Meghalaya who cannot afford this costly medicine, who cannot afford the required medicines which are required, especially those life-saving drugs, which are very, very costly. We understand how many poor family can afford. That's why, sir, I bring this motion for discussion in this house today. That as a government, I do not know, Honorable Minister in charge Health and Family Welfare, she is the best person to know what kind of treatment do we give to such kind of patients who are struggling and whom we know also that it's difficult to cure. What kind of treatment as a state government we are giving as of now? But to my knowledge, sir, most of the poor patients, they came back home when they know that they are not able to cure anymore. Sir, I want to draw the attention of the government through this motion that it's very, very important to create such facilities. And if the government can give the direction to the doctors to classify, and the senior doctor to determine, to declare which patient, who is the patient who required this comfort care treatment. If it's not there in the subject of the health department, I felt it is very, very important to have that classification, that patients who reach at that stage due to chronic diseases should be given that classification as comfort care treatment. And when the doctor declares that this patient needs comfort care treatment, the government should bear. The government should provide free of cost medicine, whatever the cost may be. The costly medicine, the injection which is very costly, painkiller which is needed is very costly. The government should bear such medicines, sir, when required to administer to service to such kind of patients who are struggling. Another suggestion, sir, which I want to bring to the government through this motion. Sir, private room, it's very, very important to give to such patients. Normally, private room is given to the patient who can pay. But I would urge the government of the day that such patient who get that classification from doctors should be given free of cost to a private room. Why we need such facilities, sir? Why we need private room? As the dictionary I've read that comfort care includes emotional care. Sir, I want to tell you the fact that spiritual care is so important in such cases. People, it is very, very important, and we believers, we believe in our different religion, but one thing which we do believe is that emotional and spiritual care is so important at the end point of our life. It's very, very important. Patients are tending always to confess even their sins that they have done, and they need a spiritual healer at that point of time. Do you think that the general ward in the hospital is a suitable place for the patient to confess their sins? Do you think the general ward is a suitable place for the fathers, for the pastors to perform their religious performance at that place? No, sir, it's not suitable. And there's time that the patient, he don't want to disclose even to their own family, but they want to have a consultation with the spiritual healers. So until and unless they have a private room, they have a privacy, how can they disclose such kind of things? For which it's not necessary for them to disclose to their families, members, but they want to disclose to their spiritual healers. So it's very, very important to provide them a facilities so that they can disclose their things for which they want to disclose only to the particular persons. Sir, there are some definition also who says that to provide a comfort care mentally and emotionally and also physically, it needs to be present there physically, try holding hands or a gentle massage to the patients, and then set a comforting mode. Some people prefer a quiet moment with few people only. And then some patients may prefer even to listen to music with low volume. That also should be provided if required. And this will help the patients with relaxation and to reduce pain even. And then another thing it says, that it needs to involve yourself with the patient, especially the attendants, the loved one, the relatives should involve with the patients, and always to be present with the patient, especially the loved ones. So, sir, my conclusion remark on this subject is that I want to see the government of the day, the state government, if we have such facilities, if we have such care, can we improve it? Can we do better? And if we don't have, so far, Honorable Minister in charge Health and Family Welfare, she's here with us. She knows better whether such facilities, such classification is there or not to the patients. I would urge this government of the day, sir, to bring this new topic, this new subject in the government hospital, to have a comfort care facilities to the patients who are facing with chronic diseases and who are struggling between life and death. With this few submissions, sir, I conclude my speech. Thank you.
Any member who would like to participate may send their slip with their names within this 5 minutes, I will now allow Dr. Shillong, honorable member, to take the floor. Any member who would like to participate may kindly send their slip.
Mr. Deputy Speaker, sir, thank you for the opportunity given to participate in this motion brought by Honorable MLA Shri Renington L. Tongkhar on the topic that this House do now discuss the need to provide comfort care treatment facilities to patients in the government hospitals. When we talk of this topic, our mind is always drawn, and in fact, it is related to the cases where they are terminally ill or cases where the treatment possibilities of a cure is not possible anymore. I will give an example of what usually happens in the hospital. Now, if the patient is seriously ill, or a cancer patient that is really suffering, what happens in our government hospital is, after a few days of treatment, the advice at best that we give to the patient parties is that we cannot give any further treatment here in our center. You take the patient home, or you take the patient to any private hospitals that you wish to take. That is the advice that we give. So in participating in this motion, I also feel like the honorable member. In fact, he became emotional also. Maybe he has experienced cases where personally he encountered the situation. I'm not an expert on this, but then as a medical doctor, I can share my views. When we talk of palliative care, this is the treatment that we give to patients that has no hope of recovery, but we give treatment to relieve their pain or to reduce the symptoms. With the passing of time, a patient of cancer or maybe any other chronic illnesses, if we tell the patient to go back home, I also subscribe to the views that the honorable member has mentioned. Patients go through the stages, the different stages of pain. In the beginning, they try to bear it. Then they start crying. Then they start rolling in their beds. Then they find it difficult to eat, especially in cases of cancer in the esophagus. In those cases, especially when the patients are very poor, they cannot even go and call any doctor to come and visit home because of the involved expenditure of bringing the doctor home. So they are left with just seeing the patient, maybe it could be a father or a mother, writhing in pain, crying. The only thing they can do is look till the end time. So in this case, maybe I would like to suggest to the government to form an advocacy group. Just like we have the medical board to certify that such and such person is having a disability, we can form a similar group where maybe a medical specialist can sit in that group, a surgeon can sit in that group, a doctor with experiences, maybe a retired doctor, where after looking at the results of the investigations, can as a group declare this patient will have no other improvement, even if you go to any place of the treatment. This will save a lot of money to the respective families. I have seen so many cases where doctors do not communicate clearly because they feel, how can I say that this case has become hopeless? Because medical treatment is not like mathematics. 2 + 2 is 4. Sometimes the treatment that we give to one patient, the patient responds very well. The same disease to on another person, same treatment is given, but the response is different. So, I can understand the dilemma of the doctors also to declare that this particular case is a hopeless case. But if there is an advocacy group that explains the prognosis or the cause of the disease, maybe if a case of cancer, if it is a 3rd stage, we should be frank with the patient parties. We should be able to tell them that the treatment prognosis is not very bright, or maybe there is no hope. If we tell the truth, what are the consequences? The family members will be prevented from selling their lands, because I've seen many families who has gone completely bankrupt. Because why? The father got cancer, they don't get the correct communication from the doctors, no proper guidance, they sell their land, they sell their vehicles, they sell everything. At the end of all the expenditure, the patient dies. And all the family members who are surviving, their life become miserable without a disease. They go into depression, so on and so forth. So, an advocacy group, maybe usually in the district hospitals we don't have the advanced care, maybe at least in the civil hospital, Shillong, advocacy group in Tura Civil Hospital, advocacy group in Jawai Civil Hospital, where that group can study the results and investigations done on the patients and tell them frankly the prognosis. In that way, the patient parties or the families will not feel guilty even if they don't try to take him outside the state. I've seen in many instances, sons and daughters come together not knowing that this case is hopeless. They spend all their earnings only to be told at the end that nothing can be done. I don't blame the nursing homes. I have seen many cases where a patient will be taken into the ICU. First day, second day, third day. It is very easy for the doctors as a team to decide whether hope is there or not. But no one will take that initiative. At the end of 15 days, the hospital bill comes to 15 lakhs and the patient is still unconscious. So I feel that is not fair. So if we have that advocacy group, when a patient is very ill but conscious, many advices could be given to that patient. For example, a terminally ill, chronically ill cancer patients, if there is a group that advises on the social aspect, that is the time, if he has not made a will, he can be advised to make a will, especially if he is a rich person. We have seen many instances in and around Shillong where family members, when the father dies, they go and fight for the properties. But from the beginning of the illness till the death of that patient, sometimes 2 years' times have lapsed. Sometimes maybe 6 months, but that 6 months was very crucial if someone had advised how to do with the wealth and properties of that person who is sick. Now, in case of comfort care, sometimes patients are sent back home with Ryle's tube or the feeding tube from the nose. Patient parties are advised you can feed them. They have been explained. Liquid food, this is how you do it. But then sometimes proper information is not given to them, that after a certain number of days, that Ryle's tube or the feeding tube has to be changed. Or maybe in between, if the patient vomits, how to handle that situation. So, counseling, telling the patients the exact prognosis, how this case will happen, or what will be the end of this patient, that is very important. Personally also, I feel sometimes very difficult to tell the patients who is seriously ill. I have come across many instances where patient party come and call me to go to their house and visit. And when I find that the patient has no hope, alone I feel it is a pain to tell them that this case is hopeless. Even I have the tendency to refer the case. But as a team, different minds, 2-3 doctors sitting together, we can give the right direction to the patient parties. I didn't get a chance to check how they do it in other developed states or countries. But maybe our government, through the health department, we can go in that line of forming an advocacy group. With that first step, maybe, that group can advise the government also what things has to be done. There is an urgent need now where we should have a hospital to treat only the terminally ill. Just like we have the old age homes, they go to the old age home, the criteria is that they are having an old age, not because they are sick. So if we have some sort of a home where people can go and that center can give counseling, spiritual counseling as rightly mentioned by the honorable member. If I talk about the spirituality of our lives, sometimes I used to tell my friends, those who get cancer in the stomach or in the throat are lucky people, because they know that they have time. If they are not living a life that is in accordance, that is pleasing to God, that is the time they correct their life. If they have hurt their friends, that is the time they call. Means they can correct their life. But I don't say that those who get cancer are blessed. A disease is a disease. But how we move from here forwards, we should be able to relieve the pain and the suffering of our fellow citizens in Meghalaya who are suffering from terminal illnesses. Let us find a way to relieve their pain. With these few words, I hope the government, considering the points given by many other members, will come up with maybe a pilot project for the state so that people will benefit out of what the health department is providing. Thank you, Mr. Deputy Speaker, sir.
Motion. Comfort care treatment is designed to alleviate symptoms, manage pain, and enhance the quality of life for patients facing serious illnesses, chronic conditions, or those nearing the end of life. So disease is very cruel, sir. There is no bar, no age bar. There is no social strata bar to patients who have endured this big challenge of illness. What is most painful, sir, is in this generation, newborns are also not out of the challenge of this very important attention drawn by the honorable member in his emotive motion, sir. Today, sir, rarely you will find any member of the community who has not felt the pain that the honorable member feels. And yes, sir, I empathize with him and the thousands of families who do not have this privilege of coming to a Meghalaya Legislative Assembly to discuss their problems. This is the dynamic nature of the Department of Health and Family Welfare, sir. We are very aware, sir, that palliative care is an expensive affair. But Government of India, Government of Meghalaya is now well seized of this challenge. We are approaching to better diagnostic centers, comprehensive infrastructures to attend to all of these various diseases that cripple the community to the extent of a feeling of helplessness. I too have felt it. And I too have seen in my tenure of an MLA the extent of damage that disease can cause to families and communities. So I have two options before me. One, just read this prepared speech. Or two, concentrate on the areas of concern and go out of the predictable nature of a minister reading out a speech. And I choose the latter, sir. I will try my best to enlighten this august house. Very often, the cart before the horse parody is an often taken route. Condemn. Look at the weaknesses. Look at the shortfalls, the shortcomings. But sir, in this day and age, sir, the Department of Health is rising to the challenge. Sir, in response to the honorable mover of this motion's point about the technicalities of LAMA, leave against medical advisory. So very often, a doctor in our facility, though his heart is with the concern for a patient, needs to leave decision taken to families and family parties. We have seen, Honorable Deputy Speaker, sir, that patients had a good chance to be treated by our doctors, but preferred to leave against medical advice. Once the patient is taken out of the care of the hospital or the facility concerned, there is degeneration. There are so many factors which lead to patient parties opting for Lama. And by the time they bring back a cancer patient to our facility in civil hospital or Tura hospital, so many experimentations have been experimented by patient parties. And usually they come at the very last, most painful stage. But yes, should a government facility prepare itself for the eventuality of this deterioration of a patient? Yes. We are strengthening our facilities through the Pradhan Mantri Jan Arogya Yojana, the PMJAY scheme. And sir, we are strengthening our secondary and tertiary care hospitalization for such vulnerable populations. What are we doing in this scheme in the government of Meghalaya with its state component of share? And the consolidated effort put in by the Department of Health and Family Welfare. Sir, we are financing and investing valuable funds to upgrade our various health facilities. The Health and Wellness Center, sir, is a scheme that circles around predominantly over and above the immediate medical attention that a patient may require, even if it's not a life-threatening situation. But it hovers around care. We are looking at a care which is curative in nature, which is rehabilitative in nature, and we are definitely including the palliative care in the packages that we offer for the universal coverage of health care for every citizen of the state of Meghalaya. So the Department of Health and Family Welfare and its huge battery of doctors, specialists, medical officers, are of the opinion that we must change gear in our approach to tackling the problems of healthcare in the state of Meghalaya, to attend to the changing dynamics of presentation of various diseases in the state of Meghalaya. We are investing heavily in the non-communicable disease program of the state of Meghalaya. Very often, sir, members may have experienced personally or in their service as MLAs, suddenly out of the blue you hear that the patient you just met in the morning collapsed and died. So therefore, preventive care has to take presence in all of our activities in our various centers. So we have also looked at improving the kind of facilities that we have in our institution and reach one step further towards the person, service to the person who's suffering the most. So we have the JAS, which is very much in operation in the state of Meghalaya. This is the Jan Arogya Samitis. Who is constituting the JAS team? Every DC in every district has been told to initiate a jazz presence in every village. You have the community, you have a convergence of our ASHA workers, we have the Anganwadi workers, and we have the village health council authorities. So this team, sir, is a team which looks at treatment away from hospital. We have home visits, we have door-to-door checking and collection of data and survey of patients, so that we are able to, as a government, expand our MHIS scheme, so that it becomes a dynamic list which is conditioned primarily not by predictable diseases that can be attended to in the universal coverage, but particularly to ensure that whenever the need arises, the MHIS should and must coverage any disease and requirement thereof by a citizen of the state of Meghalaya. So we also have worked on the e-Sanjeevani networking, what we call digital health integration, so that a patient who is in need of medical advice and attention, even if being treated at home, can access through these teleconsultations that are there. But maybe awareness is the need of the hour. We have to publicize the presence of these institutions that are there at every village level. Today, in the e-Sanjeevani networking digital health integrated system, we have 51 specialists which have onboarded themselves. But maybe people don't know. So palliative care, like I said, has no age bar, has no community bias. It is across the board. And the state, in its ambitious intention to start the 2 medical colleges which are run by the state government, will also achieve the same end. We have been finding problems finding specialists. So what is most painful is that Alzheimer's, dementia, and other such diseases are slowly consuming our population. And sometimes the way out is to educate the masses. We have to educate the masses to move away from practices which have been practiced for long. I have a cancer, the doctor can't treat me, let me go to a natural healer. Does that work? We need to fight this. A systemic corruption within ourselves, which is detrimental in the long run to the population at large. We need these specialists, and these 2 medical colleges will create the gap that is there, and that is why we are determined. And I must also thank the Honorable Chief Minister for his constant support to the Department of Health and Family Welfare. Time to time, we go to the Honorable Chief Minister to discuss the dynamic manifestation of some of the some of the diseases that are slowly becoming important. I am confident that 5 years down the line, we will have trained personals. Today, neuro-onco-surgeons are rare in the state of Meghalaya. Hence, patients have no option but to leave the comfort zone of their homes and get treatment in another location, another state, sometimes even overseas for those that can afford it. We are confident, sir, that the psychiatry department in the state organizations will strengthen. Suicidal tendencies. Once upon a time, sir, we used to read in a novel or see in a film. But today it is a practice. Today it is consuming the community and corrupting the mind of the community to a large extent. Should the government be a mute spectator? No. We will rise. And we will see how we include the education department, the teachers, the physicians, the ASHA workers, the Anganwadi workers, so that we fill the gaps and start discussing our problems. What is this non-disclosure of position of health or status of a health or an ailment of a patient? Very often, our community, we are not ready. I often ask doctors in my visit to the districts and different locations, in the several numbers of inspections that I have personally gone and attended, why don't you tell the patient the truth? Many doctors themselves need a training. What do you disclose and what can't you disclose? Modern practices are now a common trend. We have to train our personnel, which is why we invest so much on medical education and career progression of our staff. We are forcing our medical officers who are refusing to go for advanced career progression programs because they are happy in their comfort zones. We are changing. Our doctors are changing, sir. Gone are those days when doctors become consumed by their comfort zones. Our doctors are now very hard working. I know in a PHC is likely the only source of hope for the hopeless. We are requesting our doctors, sir, to walk the talk. But training and exposure trips, sending them to facilities where all of this is included in healthcare, is what we need to do. Sir, civil hospital in Tura, the tertiary care hospitals, are also improving in their services. And yes, we have to remember that sometimes when a patient has lost all hope in medicine, he turns his hope to God. We are a Christian state. Whether you're Christian, you're Hindu, you're a believer. All believers have their own corrective, supportive treatments for patients. And I request patient parties to reach out to the various groups that are already in operation. So we have, like Dr. Celestian Lingdo, the Honorable Member of Umsning, has requested us to have advocacy groups. We have several groups, sir, for people suffering from various ailments, be it cancer, be it HIV/AIDS, be it drugs. We have these advocacy groups, and we are also working to include them in a lot of our activities in all of our facilities. Sir, I could go on and on as to what the department is already doing. So today, Civil Hospital has what we call a respiratory care unit. Today, we have the counseling and therapy and psychological clinics in Civil, in Tura. We are going one step further, sir, and we're also having an adolescent health-friendly clinic with the rate at which young adults expose themselves to risk. We have to talk about it. We are doing it. We have the complementary therapy services like acupuncture, massaging. We've built a very strong Ayush department. We now have the naturopathy department. We are encouraging yoga, meditation, and inculcating holistic wellness and stress relief in our community. Sir, even the simplest things like hygiene and self-care, communities across the state still need hand-holding on that. On the International Women's Day celebration, I was so happy to be giving sanitary pad vending machines to institutions. We have to talk about it at the rate of 10 rupees. What is cervical cancer? This morning I attended a funeral where a very senior citizen discovered at the fag end of her life that she had cervical cancer without any knowledge. The other day I went all the way to Pacharat Mangar's constituency, where again there was a senior lady who had no inclination. We are now encouraging tests. We are encouraging citizens to be concerned about knowing your own body. Most of the time, most of us do not want to go for screening. But sir, today the department has conducted so many screening tests across the state of Meghalaya. Therefore, sir, when you look at the kind of increase of footfall of patients in all of our facilities, one positive indicator, the rainbow behind that cloud, is that we are increasing our footfalls, which means people are now sensitized and educated that they must reach out for medical help and they must know their bodies. And we will try our best to continue in this direction, and we will try our best to include all kinds of diseases in this huge obligation that we have to the population of the state of Meghalaya. I thank the honorable members, both of them, for participating. Important for us to share some of the efforts that we have made in the department. So there was a mention of private room facilities. Sir, we are trying our best to also improve our infrastructures in our various centers. We are working hard to ensure that performing institutes are given this additional help assistance to increase the number of private rooms in their various facilities. Sir, Government of Meghalaya is equally concerned on this seemingly extremely difficult avalanche that is hitting the department to change its practices and its ways. And we are studying ourselves, we are evaluating ourselves through various ways. The various awards initiated by the Honorable Prime Minister, our facilities now are getting all of those awards. It is self-evaluation, introspection. What is it that we need to do? And let me assure this Honorable House, sir, that we will be on the job. We will work hard. We are working on ensuring that we improve and expand the HR in our various institutions. We are grateful that the Honorable Chief Minister has given us more nurses, more doctors. Earlier on, when the state was first formed, the Department of Health was this small, but today we have expanded. We are grateful to the NHM, the Honorable Prime Minister, for the various interventions that have occurred to enable the Department of Health and Family Welfare to expand itself, to rise to the occasion, and to face these challenges which are very dynamic in nature. I hope, sir, without giving too much information on data to the two members who have risen on this house to participate, I hope that I have been able to satisfy your learning. I hope that I have embalmed the pain that you feel. I hope you have confidence in your own government. And I want to assure every member, sir, and the public in general, we will try our best, we will rise, and we will concentrate on early detection. We will concentrate on improving our diagnostic centers. We will concentrate on increasing our screenings. We will send our doctors for proper trainings. And I hope, sir, that by 2032, on achievement of the $10 billion dream that we are piping, our facilities will also benefit, and our efforts will continue to protect whom? Of the people of the state of Meghalaya. With these few submissions, sir, I resume my seat, sir.
Thank you.
Yes,
Nongpang.
I have one clarification, sir, and first of all, I must thank the Honorable Minister in charge, Health and Family Welfare, for replying this motion. Of course, sir, I am happy to hear from her. There are so many things that the government has initiated to help the patient, but we know that it's still not sufficient, sir, especially MHIS. We know the fact that under MHIS, patient still have to pay, and only certain amount that can be recovered from MHIS. Sir, I just want to put a very specific question to the Honorable Minister. And I just want to remind this House that there are many things that Meghalaya do, and then the rest of India follow. So I want to put a specific question: if the government of Meghalaya examine to create a comfort care hospital, at least one hospital in Meghalaya, comfort care hospital? Because you see, sir, all these days we are talking about how to cure, but now it's beyond the curing. That those patients whom we know that we are not able to cure, so we need only to keep comfort. So will the government examine to create a comfort care hospital in the state of Meghalaya. Sir. This is only my question. Sir.
So the government of Meghalaya, through the Department of Health and Family Welfare, is well versed with a comprehensive geriatric care. It's a consolidated policy. Yes, it is always, we are always ambitious of expanding our facilities. I will not commit here, but I will assure the Honourable Member that in the existing centres, we are already designating a 10-bedded geriatric ward, civil hospital, Shillong and Tura, Jowai. We are on the job, sir, and we hope to be able to achieve it, sir.
Thank you.